Heart failure, or I have no disclosures. Next slide. The objectives today are to review the heart failure diagnosis, the types of heart failure, risk factors of heart failure, symptoms of heart failure, signs and symptoms to monitor for, medications and treatments. I will review the common ones, and prevention of future hospitalizations. Next slide. Heart failure is a common clinical syndrome in which symptoms result from a structural or functional cardiac disorder that impairs the ability of the ventricle to fill with or eject blood. Next slide. Heart failure is a chronic progressive condition that worsens over time. It is very common. Although we have made progress in the treatments of many forms of heart disease, heart failure remains a growing problem in the United States. Current estimates are that nearly 6.5 million Americans over the age of 20 have heart failure. It is the leading cause of hospitalization for Americans over the age of 65, and one of the main causes of readmissions to the hospital. One major study estimates there are 960,000 new heart failure cases annually. Not only is heart failure a major problem affecting many people, heart failure is also a major killer. Heart failure directly accounts for about 8.5% of all heart disease deaths in the United States. And by some estimates, heart failure actually contributes to about 36% of all cardiovascular disease deaths, affecting nearly 23 million people worldwide. Next slide. In heart failure, the heart muscle gets injured and loses ability to pump enough blood to supply the body's needs. It can involve one or both sides of the heart. There can be a reduced or preserved ejection fraction, which we'll get into that in a minute, and can affect the left side or the right side of the heart, or both. Left-sided heart failure is also referred to as left ventricular dysfunction, as well as right-sided heart failure. Next slide. In left-sided heart failure, there are two types of left ventricular dysfunction. Systolic, where the left ventricle is too weak to push enough blood out to the body, or diastolic, where the left ventricle is too stiff or can't relax and cannot fill with blood normally. Left ventricular dysfunction can be measured by left ventricular ejection fraction, which is how much blood the left ventricle pumps out with each heartbeat. Normal ejection fraction is about 50 to 70%. And some of our classifications are listed there. HFrEF, which is heart failure with reduced ejection fraction, where the LVEF is less than or equal to 40%, also called failure with preserved ejection fraction, where the EF is greater than 50%, also known as diastolic heart failure. And then we have heart failure with medium or mildly reduced ejection fraction, where the EF is 41 to 49%. We also have a term that we've been using in clinic lately. It's heart failure with reduced ejection fraction now recovered. That's if the patient does respond to the treatments that we prescribe. Next slide. Right-sided heart failure, the right side of the heart is not pumping to the lungs as well as it should. Right heart failure may develop acutely or chronically and is caused by acquired or congenital forms of cardiovascular disease, lung disease, or valvular heart disease. It is the dysfunction of the right heart structures, such as the right ventricle, tricuspid valve, and right atrium or pericardium, resulting in impaired ability of the right heart to perfuse the lungs at normal central venous pressures. Most forms of left-sided heart failure, particularly HFpEF and various causes of HFrEF. Right heart failure usually follows left heart failure due to association with pulmonary hypertension and pulmonary congestion. Next slide. Risk factors for heart failure are many, including hypertension or high blood pressure, coronary artery disease, or fat deposits creating blockages in the heart's arteries, which can lead to a myocardial infarction or heart attack. Valvular heart disease, which is damaged heart valves, or if you have a history of a heart murmur, you can also have valvular abnormalities. Arrhythmias such as atrial fibrillation or sinus tachycardia, which can lead to myopathies or any cardiomyopathy that relates in heart muscle disease or enlargement. Next slide. Continuing on with the risk factors are congenital heart disease, which are heart defects at birth, familial cardiomyopathies that are genetic disorders affecting the heart, diabetes, obesity, or pulmonal, such as related to or caused by severe lung disease or sleep apnea that is untreated, thyroid illegal drug or alcohol abuse, which can lead to worsening weakened heart muscle, and tobacco abuse. Next slide. Symptoms of heart failure are dyspnea or shortness of breath with exertion or at rest, paroxysmal nocturnal dyspnea, which is waking up breathless at night, orthopnea, which is when you need 2 or more pillows to sleep comfortably at night, exercise intolerance, which is fatigue or weakness, and you're not able to perform your daily activities, frequent cough, either a dry hacking cough or one with sputum production. Sometimes it is a pink or blood-tinged sputum. Edema, which is swelling of the feet, ankles, legs, or arms, or the abdomen, which we also call ascites. Weight gain due to excessive fluid, not from eating too much. Decreased appetite or nausea are common symptoms when you are having an exacerbation. Increased need to urinate at night, a rapid heart rate or fluttering in your chest, and poor concentration or increased confusion due to lack of perfusion. Next slide. When symptoms of heart failure progress, it can lead to symptoms of low cardiac output, such as debilitating fatigue, exercise intolerance, unintentional weight loss or cardiac cachexia, refractory volume overload that is not responsive to diuretics, recurrent arrhythmias or ventricular arrhythmias especially, hypotension or narrow pulse pressure, cold legs or arms, which is a sign of poor perfusion to the body's extremities, and difficulty concentrating or mental status changes, which is a sign of poor perfusion to the brain. Next slide. There are 2 ways we classify patients with heart failure. One way is using the New York Heart Association classification for functional class, which assesses the severity of symptoms and how much patients are limited during physical activity. There are 4 classes, and they are listed here. Class 1 is a patient with cardiac disease with no limitation in ordinary physical activity. Class 2, the patient is comfortable at rest, but ordinary activity results in symptoms or slight limitation. Class 3 is comfortable at rest, but less than ordinary activity results in symptoms or marked Class 4, they are symptomatic at rest. So any or they are having increased discomfort with any physical activity, and even at rest. Next slide. The second way that we classify is using the ACC, which is the American College of Cardiology, American Heart Association stages of heart failure, that recognizes both risk factors and abnormalities of cardiac structure are associated with heart failure. These stages are progressive and are as in this slide. Stage A is a patient who is at risk for heart failure but without structural disease or symptoms, such as if they have hypertension or diabetes. Stage B is a patient who has structural heart disease but without heart failure signs or symptoms, such as a patient with a history of myocardial infarction or a decreased ejection fraction, or even with valvular heart disease. Stage C is a patient with structural heart disease and with a prior episode of heart failure, meaning having either hospitalization or symptoms of heart failure, such as the shortness of breath, weight gain, swelling, etc. Stage D is refractory heart failure symptoms requiring specialized interventions, such as symptoms despite maximally tolerated doses of therapy, repeated hospitalizations, and even requiring advanced therapies such as inotropes or LVAD device or even heart transplant. Next slide. Signs and symptoms that we should be monitoring for in our patients on a daily basis include weight gain or weight loss, blood pressure or heart rate changes outside of the normal range or significant changes of, increased dyspnea, orthopnea, PND, this is the shortness of breath symptoms that we talked about, changes in exercise tolerance, such as worsening fatigue or just not being able to climb a flight of stairs or do things that you normally could do, increased fatigue, increased cough, swelling of the legs or abdomen, increased episodes of chest pain, or signs of decreased perfusion such as confusion or cold extremities. If you notice any of these changes, your patients should be encouraged to report them early, as early intervention can keep your patients out of the hospital. Next slide. The most common medications that we use to treat heart failure include ACE inhibitors or ARBs, which are angiotensin receptor blockers. These lower blood pressure and reduce workload of the heart so it can regain strength. The newest medication is the ARNIs. I can't say the word. It's a just label it as an ARNI. It's an ARB with a special medicine, and these may be used in place of the ACEs and ARBs. And the major one we're using these days is the Entresto. The very good data that we have with the Entresto. Beta blockers, which slow heart rate and allows the heart to more efficiently pump blood, and helps the heart to regain strength. The MRAs, or mineral corticoid antagonists. It removes excess of fluid and prevents loss of potassium. We use nitrates and hydralazines, which also lower the blood pressure and reduces workload of the heart. These are usually used for patients that can't tolerate the ACEs, ARBs, or ARNIs due to renal dysfunction. Let's see. The cardiac glycosides, which is like digoxin, helps heart beat stronger and pump more efficiently, and diuretics, which remove the extra fluid that the body retains. Next slide. For prevention of hospitalizations, we need to proactively manage the disease by teaching self-management strategies. The most important way is to educate our patients on these things. So education is the most important thing. We educate patients on their medications and medication adherence. We educate them on their dietary choices. Most importantly, a low sodium diet, usually 2 grams of sodium in a 24-hour period of time, and fluid restriction. We usually limit our patients' fluids with advanced heart failure to either 1.5 to 2 liters of fluid, on the importance of daily monitoring of their weight. And we tell them to weigh themselves at the same time every morning, wearing the same amount of clothing. And that's usually after the first morning void. They should record that every day on a calendar to see the trends in their weight changes, and so that they can report early for significant changes. They should also be monitoring their blood pressure and heart rates daily, before meds and after meds. We usually tell them 1 to 2 hours after meds just to see the response, and then to let us know when we have their appointments. We encourage them to do daily exercise to keep their exercise tolerance up, and also to monitor for significant changes if they're not able to complete the same amount of activity in the same time frame. We educate them on the importance of adequate rest, and not overdoing it, and also at risk factor modifications such as taking care of their diabetes and other health problems. Next slide. Some self-care guidelines that we review with our patients in clinic at each visit. We give them a chart going over the red, yellow, and red zones for heart failure monitoring. In the green zone, that's the good zone, or the all clear zone. The patients are asymptomatic. They're not having any increased shortness of breath. Their weight has been stable. They're not having any weight gain or weight loss. There's no swelling of the feet, ankles, legs, or abdomen, no symptoms of chest pain, and no decrease in ability to do daily activities. The yellow zone is a caution zone. We educate our patients to notify their providers if they have gained 2 pounds in 1 day, or 5 pounds or more in 1 week. If they have symptoms of increased dyspnea or shortness of breath, increased swelling in their legs, abdomen, arms, fingers, increased fatigue or feeling tired, lack of energy, a new cough that is dry or with sputum production, increased lightheadedness, dizziness, or feelings of feeling uneasy, or having a hard time breathing when lying down, which would be PND or orthopnea. The red zone is the very, we try to not get to this zone. We tell our patients that they should call 911 or go to the nearest emergency department if they are struggling to breathe, have unrelieved shortness of breath, having any chest pain, or increased confusion or cannot think clearly. These symptoms are advanced and a sign that too much organ edema that is not allowing them to absorb their medications appropriately, and needs prompt attention, period. When they get into the yellow zone is when they should be notifying us so that we can prevent going into the red zone. Next slide. I put these next 2 slides here just as a reference for providers out in the community for when to refer to a specialist. It seems that sometimes we get referrals that are too late and we can't help these patients, which is very concerning for us, because we have options that we can do if we get to patients early. So this list, these 2 slides are very important. That's when they're having persistent symptoms of the class 3 to 4 symptoms of congestive heart failure, like we talked about. If they have a systolic blood pressure less than 90, or symptomatic hypertension that they just are unable to tolerate their medications, that is a sign of advanced heart failure that needs treatment by a specialist. If their kidney function is suffering, so their creatinine is greater than 1.8 or their BUN is greater than 43, that means that's a sign that they're having some end organ dysfunction that sometimes with treatment of the advanced heart failure with advanced therapies, this can be corrected, period. So I'm not going to go through all this, but there's the list there is important if you are wanting to know when to refer. And then the next slide continues on to those as well. Let's see. In conclusion, next slide. Heart failure is a progressive condition that starts slowly and can get worse over time. Life expectancy depends on many factors, and controlling these factors that we have discussed in this talk can sometimes and hopefully lead to greater life expectancy, and leads to controlling the progression of the disease. Education of patients and families in the diagnosis, symptoms, management therapies, and early reporting are key in preventing hospitalizations and can prevent complications. Close monitoring and early referral to an advanced heart failure specialist can increase life expectancy. That is the conclusion of my discussion. These are my references that I have used, and I will take time for any questions that you may have. Thank you.
Thank you so much, Jennifer. That was excellent and very informative. So we did get a question in through the chat. So when you mentioned to prevent hospitalizations, you mentioned daily exercise. What types of exercises are recommended?
Generally, when we have a patient that has come, say we get a patient from a hospitalization that had a heart attack and then they had bypass surgery, we generally let them, limit their activity for a period of time, and then we would normally enroll them in a cardiac rehab program. Generally, before that time, though, I tell my patients to just do walking, just walking on the flat, and then gradually increasing it in time span, starting off at 5 minutes, 10 minutes, 15 minutes, and then as tolerated, you gradually increase it with 5-minute increments as tolerated. They can sometimes start to do stair climbing if they feel up to it, and then go from there. Enrolling in a cardiac rehab program will help you to progress through the stages, and then they are monitored during those sessions to increase their tolerance. Once they've completed a cardiac rehab program, if they're able to, some patients can't do that due to insurance issues or whatever, then we would recommend introducing light weights and things like that. But that would be a step-by-step process as they're tolerating it.
Thank you. Were there any other questions for Jennifer and her didactic? I know Donna was having some connection issues. There was another question asking if there was a family member with heart failure, are there any genetic factors to be aware of, and any types of preventative measures?
There are, and actually, when you have a family member that has heart failure or a history of heart failure, and then you have heart failure, especially in the young population, and we're not exactly sure what the cause is, especially if they have have had pregnancy and now have a new diagnosis of cardiomyopathy. So we generally will refer all of those patients with a family history of heart failure. When we don't know for sure, we'll refer them to a genetic counselor for genetic testing, and then they can review, after the testing, all the genes that are significant for that disorder. If there are genetic disorders that are found, then they generally will have family members from that patient's members of the family tested in order to be able to prevent further, or catching things early, or treatments, and then or closer monitoring of those patients. So definitely we refer to our genetic people all the time, just because there are a lot of genetic disorders out there.
Absolutely. Thank you. Any other thoughts, comments, questions? Let's see. We got a chat in from Donna saying there were some connection issues, but what she could hear and everything was very helpful, and she thanks you for that. She'll review the slides from the recap email. So thank you, Donna,
Okay.
for that chat. All right. Well, thank you so much, Jennifer. That was an excellent didactic. I will attach your PowerPoint to the recap email just so everyone has a record of that as well. Just a couple housekeeping announcements. Our next session will be on August 21st, and Dr. Sokos will be providing the didactic on distinct cardiac-related symptoms. So keep an eye out for that reminder. Thank you all so much for joining. The recording from this session will be posted on our YouTube. So I know we'll have a lot of people watching those on their own time as well. So we got a chat in from Trisha saying excellent presentation. Thank you so very much. So thank you so much. We'll see you guys next time.
Okay, thank you so much. Have a great weekend.
You too. Bye-bye.